Okay, folks, this is Alex and Reza, and we are so excited to welcome Shami Feinglass and Mahesh Krishnan here, two amazing physician leaders and executives in the DC area, and they've written a book called The 60-Minute Clinician MBA. Anyways, so excited to have you both here and to learn more about the book and what led you to write this book. So, Shami, maybe we'll start with you. Tell us a little bit about yourself and your career, and then we'll go to Mahesh.
Sure. Alex and Reza, thanks for having us today. This is always fun for us to do. I am a native San Franciscan, and the reason I always start with that is my parents helped found the Haight-Ashbury Free Clinic. So for me, health has always been accessible. I didn't realize there was any problem with our healthcare system or that people couldn't get care. So growing up there, then going to college on the East Coast, medical school in the South, residency in the Pacific Northwest, and then coming back out for my first job after fellowship being at Medicare and working to look at how you can use evidence to make policy decisions. I recall when they hired me for that, I didn't really believe the government used evidence to make policy decisions. I now know they do. But having been there, that they do, they have the ability to, Reza, they really do. We did, and again, that's my usual MO. I was like, let me kick the tires on this because I'm not so sure it works that way. But while I was there, I was also in the public health service, so got to do two things, right? So I got to work at Medicare, make policy, help create coverage with evidence development, and some things early on that were really helpful for what we see today at Medicare. The other piece was I did a lot of disaster management because I was in the public health service. And for me, it was all really interesting. Got a second residency in preventive medicine and then went on to go work in industry. And so my first job out was to run medical affairs, clinical reimbursement, and then later regulatory at a large orthopedic company. Some of you would know it as Zimmer. And it was multinational, and I had to manage teams all over the world. From there, I raced bikes for a little bit, which is a whole nother story. And then went to Danaher, and again was handed really a blank sheet of paper to create a job. Both cases, the jobs that I took didn't exist before I was there. While at Danaher, I had a variety of jobs and ended up as the chief medical officer across life sciences and diagnostics, and then called the pandemic for the company, so ran that for 80,000 people globally. Finally, when I left Danaher, I was helping work on mental health reform and then came to Manat Health Strategies to help be able to have people think about health going forward. Finally, I serve on a few public traded boards and spend a lot of time with my co-author Mahesh, because he has always been someone I call when I'm stuck. And so together we created this book.
Wow.
Amazing.
Before we jump into Mahesh, with the racing bikes, we're talking cycling or like motorbikes?
I race BMX.
BMX.
What?
I love it. It gets more exciting. All right. Mahesh, can you beat BMX?
I cannot beat BMX. Shami's actually a nationally ranked BMX person, so not just a hobby. So Mahesh Krishnan, I'm a nephrologist. My story is a bit similar and a bit different in that I went into healthcare really to change the world, right? That was sort of the prototypical thing when you write your medical school essay, but I really wanted to do that. I'm a very systems-oriented person. So when I see systems, I see the problems, I see the way they work, I see the way they could be fixed. And while that could be a good thing, when I first went into private practice, that was a bad thing. In that the healthcare system that I encountered when I first left my fellowship in nephrology and went into practice in Northern Virginia was horribly broken. And so I tried Herculean things to improve the care of my patients. I would round after hours, I would do all sorts of crazy things to sort of compensate for a system that was terminally broken. And at the end of that, I pretty much burnt out. But I couldn't provide the level of care that I wanted to provide for my patients despite my efforts. And it was costing me things on the family side, on the personal side. And so I kind of burnt out. I was fortuitous in a way that I had done a lot of work with pharmaceutical companies at that time before. I had written my first book, which was a book meant to allow pharmaceutical representatives to detail academic medical centers. And I had done a lot of sales training for multiple different healthcare companies at the time. And so as I was burning out, one of those folks that I worked with said, hey, did you know Amgen was looking for a medical director for Epogen at the time? And so I took that job. I made the transition from after 5 years of clinical practice to go into industry. Led a bunch of things at Amgen for 5 years. This is actually a theme with me. I switch careers every 5 years. So the second 5-year theme at Amgen was coming to its end. And I got a position with DaVita, which, as many of you might know, is one of the largest kidney care companies in the world. I started off in research. I ended up running their international medical affairs organization for 5 years, building clinics in 240 clinics in 13 countries. And then for the last 5 years, have really been running the venture group and the external innovation group at DaVita, while at the same time doing a lot of public policy here in Washington, D.C. I'm the current chair of Kidney Care Partners in DC. And at the end of the day, I have developed an affinity to train clinical leaders. And I say clinical leaders, not just physician leaders. I do a lot of mentoring, both within the organization and outside of the organization, for physicians, nurses, dietitians, social workers, folks that are subject matter experts on the clinical side that need to be more interoperable with their organizations. And so as we sort of did this, had that conversation, Shami and I, we found that we were both very interested, and that's what created the book.
So quick comment, I also briefly worked at DaVita on the medical group side before we got acquired by Optum. And I remember they had a lot of training programs for clinicians, MBAs, others. They had this Redwoods program where they would get these top-notch MBAs coming from first-tier business schools to come in and rotate, etc. So I always think about, there was a time, and I don't know, maybe it's still the case, there was a time that DaVita was kind of like developing up-and-coming executives. A lot of these folks I know have moved on to done amazing things, kind of like GE was kind of a decade before or 2 decades before. So walk me through, like, you were at DaVita, there was a lot of infrastructure, a lot of education, good, bad, in some ways. What was missing that you thought, okay, we need to add something to what's available here, at least at our company?
Yeah, I think the training programs that you speak of still exist, right? And they produce, as you point out, amazing executives and amazing alumni that have gone on to do tremendous things. I like the analogy of the GE of healthcare. I think that's quite apt. I think the thing that is probably missing is, how do you customize that training to a clinical audience? It's one thing if you are an MBA, you come from a professional experience that is more corporate. But if you come from a non-corporate environment, say you are a physician in private practice, or say you're a physician at an academic medical center, and you make the transition, whether it's DaVita or Danaher or any other company, right, that Amgen that you think about, what is the system that allows you to understand the fundamentals, speak the same language the others are speaking? How do you avoid being a July resident or medical student indefinitely? That requires training, right? It's not something you can learn by mistakes, or you can get some training. And so I think, Reza, that's what we felt was missing, is how do you customize and condense that education so that you're more likely to survive July and August than you did before? And it seems like that is missing writ large in the industry. There's a number of books that are out there that talk about different things, number of courses. Obviously, I know, Alex, you do a lot of work with your clinics folks, but an actual curriculum to do that seems to be missing. And maybe the way that I understood that was the case was I would get asked both internally and externally to teach people this, right? They say, Mahesh, you seem fairly successful in what you're doing. You seem to be able to manage your budget, be able to hit milestones on time, attract and recruit talent, and train them. Help us do that so we can be more effective. And after getting asked that many times, I decided that the best way to do that would be to syndicate myself in a book.
Since you can't clone yourself yet. I think the other thing in answer to that, Reza, is that this clinical focused piece is key. Like at the companies I was at, clinicians didn't even know what capabilities they might need to go to the next level. So we're not even talking about clinicians immediate, like just into industry. We're talking about some that had been there for years, and this is a global phenomenon. And so one of the things that I did a lot of in both of my industry roles was look at the capabilities that you need to succeed. Again, feeds into our book. And to the language piece, what's very interesting is each company has a different culture, right? The most interesting thing for me about Danaher is they have an entire Danaher business system. They have their own language. And my teams had been there for longer than I had, and the language just still didn't translate. And those things were really critical. The final piece was when I came to industry from government, the first thing I did was ask for a coach because I didn't know how this organization worked. And I didn't have some basic skills like HR. How do I manage large global international teams? What are the regulations or laws I have to stay within? And it was interesting because when I asked for this, they said, yeah, but there's nothing wrong. Like there's nothing we're trying to change in you. I said, I don't know your system or your culture. I don't think a coach is punitive. We've had mentors, coaches and sponsors all through our academic careers, through my government career. Like you can't succeed without them. So I didn't expect to succeed with that one, but it was a rarity to ask for a coach.
Tell me a little bit about how you two met, and then at what point, how did your relationship evolve over time? And at what point did you guys decide to write this book?
Yeah, we have a mutual friend, Todd Ibrahim, who's the executive director of the American Society of Nephrology, who we both spend a lot of time with we're spending a lot of time with in our respective silos. And he was like, you two got to meet. So he connected us. And then it turned out that Shami and I had another connection from a DaVita side, from someone in her family that worked for us. But we were just talking on a regular basis, usually coming up with, as physicians do, crazy ideas on how to fix the world. And sometimes as physician dues, not actually executing on any of those, right? We'd have a lot of conversations, but it didn't necessarily translate into something. And then I was asked to do an offsite for one of the groups at DaVita. And I said, they're like, oh, can you come to the offsite? And I said, sure, how much time do I have? They said, you're the entire offsite. I said, what do you mean? This was one of the medical officers group. They said, it would be great if you could teach us what you do because you're a much more successful clinical executive than many of us are. And so I put that content together. And as I put that content together, it seemed pretty clear to me that that content could be the basis for a book. And so I mentioned to Shami that I was interested in writing a book. And then Shami was also interested in writing the book. And I'll tell you how she set up an accountability system to keep me on track.
Well, I think the funny part of that is like, so Todd, who's our mutual friend, I had known since I first started working and had graduated from college. So he's always been good at matching people up, I think. The other piece was I had been writing during pandemic about clinicians working in industry, how industry can work with government, how industry can work with other parts of the private sector and academic institutions, and pulling that together because we had a crisis. In that, I was looking at the physician skills or clinician skills in an organization that are essential during a crisis period. Like the biggest one was we're trained to triage. Like we triage really well, and that is ingrained in us. It is second nature. And so I began writing some articles with another colleague of ours, Curie, who at the time had been in industry, had been in government before that, now is with a nonprofit around all of the community health centers in the US. But at the time, I said, Q, we have an ability to impact this, but people don't understand that we have a skill set that's essential at this time, but also that skill set is essential in non-crisis times. And this piece about triage and also about strategy was essential. And so again, I was probably bemoaning something when I called Mahesh and I was like, this is killing me. And every time I'd call you, Mahesh, you would say, you need to write a book. And I'd say, Mahesh, I'm never going to finish writing a book. No, I always need a writing partner. Like I have the ideas, they go. And then someone has to organize me. And so at the third time he said, you should write a book. I said, all right, let's meet for coffee. What do you have? And then he slowly dropped in, oh yeah, I've been doing these talks at my company. I said, Mahesh, you should have led with that at conversation number 1. And I'm like, in, as long as we're organized about it. So it took 2 of us. We have 2 different skill sets that mesh well, but it was from 2 different ideas that were very similar. But also, we've had a professional relationship and friendship for years. And so this was sort of the natural offshoot of that.
I love it. I love it. So Alex and I have known each other for 20 years and have gone on a similar journey recently. You know, one of the things our people in our course have been asking for is examples, right? So give me a couple examples of the counterfactual, like, you know, people you've met along the way who come in and they have an idea and they haven't considered all the other things that now, with a little bit more structure and training, can become a lot more hopefully effective in their organization and otherwise.
Yeah, I can lead. And the book is structured that way, Reza. So 2/3 of the book is the basics of an MBA with clinical examples, right? Shami mentions triage, and we think that has applicability, or how we communicate with patients, how that has applicability in translating that into the business world. The residual 1/3 is actually an anthology made up of successful clinical executives that have made the transition. So Kate Goodrich is in there, for example, who's the CMO of Humana, or Abhinal Shah, who was the prior Livongo CMO, and who's now over at RA Capital. So yeah, I'm happy to give you some examples. I have been in numerous conversations. There was one at DaVita 5 or 6 years ago, where the clinical group had decided that they really had this idea of something that could improve patient care, but would cost money in the short term. And they had worked on it, and then eventually they had to present it to the chief operating officer at the time and ask for money. And so I got a call. They're like, we'd like you to present it. And I said, you know, guys, I haven't been involved in this conversation. Why do you want me to present it? They said, well, you're really good at speaking their language. So what you need to do is translate all of our clinical ideas into something that actually makes sense from a business perspective, and that you can pitch to the COO and see whether or not he's interested or not. And we'll be there to back you up, but we need you to be there, and we need you to be there to answer those questions. And so I did just that, and we got the money, and that's actually resulted in a very significant reduction in catheter-related bloodstream infections across the company, which people always point to. But that inability or that recognition to have a clinical idea and translate it into something that can actually be funded is a skill that many clinicians don't have. And kudos to the folks that recognized they didn't have that skill set, and they helped me translate that. But that's a practical example I could give you. Shai, would you have one?
Yeah, I think the ones that are interesting to me are because I've always worked in companies that are creating products. And so there are some great scientists and clinicians in the companies that I've been in and the companies that I'm still affiliated with. But they'll have these great ideas, and they can't get them through a pipeline, even though it's really a great idea. Either they missed figuring out what the reimbursement was, or people didn't get buy-in because they didn't see how significant it was. Or on the other side, they're designing something that is absolutely not clinically relevant. And the interesting case is when they can't convince people, so let's say the engineers that are designing the product, when they can't convince them why it's not clinically relevant, that's often when I would be called in. And in one case, we were designing a test, and it has a swab. And as we all know as clinicians, there are certain parts of the body that you want to use different types of swabs on. Bottom line is, without going too deep into this, it was the wrong swab design for the space that it was supposed to be sampling. It would have been incredibly uncomfortable and led to huge adverse event reporting. And I remember one of my chief medical officers called me in and said, hey, I need you on this call. And he detailed what it was. And I started laughing. I said, are you kidding me? It's a Q-tip versus a wire brush. The wire brush is not appropriate for all surfaces of a human body. The Q-tip usually is. So why is this hard? They said they don't understand because a competitor, they say, is using the wire brush. I said, there's no way. There's no way. So bottom line is, it took us, I thought it would be one conversation. They'd call me in because I know how to communicate with the team. I thought it'd be one conversation. It was a series of conversations over, I shit you not, 6 weeks to have the right swab put in because it wasn't clinically relevant. So the clinical relevance piece, all of us have when we come to industry, but we can't speak that language. And that's where the problems come in.
So I want to ask you guys a question. You guys, as well as us, we've taken this approach where we've identified a need, right? That physicians need to learn the language of business, and they need to be able to speak across the different domains and silos. But my gut says that that's not enough, right? And I think we all know that. It's like reading a book about chess doesn't make you a good chess player, right? So how do we accelerate the other pieces that physicians need, the actual real world experience that they need to actually succeed?
Yeah, Shami and I were just talking about this, right? When you write, generally when you write a book, there's a standard recipe. So the recipe is you write the book, you figure out what ancillary things you want to do. Do you want to set up a community? Do you want to set up master classes that are asynchronous? Do you want to set up private mentoring? Do you want to set up something else? It is a question that we have not yet answered. We're sort of balancing the ability of what we want to do with our ability to actually get those things done with everything else that we do. But I think, Alex, the right answer is there needs to be a class and then continuing support. You can translate these things into a class similar to what you guys do with Clinics. But I think what we need to do is sort of build a community where you can have this ability to either ask questions to get answers from your peers or have the appropriate mentors. Shami and I have often been approached to be mentors for lots of folks, so much so that we're now overwhelming our ability to do that with the time that's required. But that's what you need, right? Like that's what you need. If you remember back to residency, you survived because you knew someone, right? You knew a buddy that was a chief, or you knew a buddy that was a senior resident. And when you said, I'm going to do this lumbar puncture, do I use this needle or that needle? You went and asked somebody. We got to figure out some way to create that network, either electronically or virtually or peer-to-peer, in order to continue to evolve the caliber of physician leadership that's required really to improve healthcare at large.
And I think it's, when you take the notion of see one, do one, teach one, right, which we all learned, that see one, that mentoring around that is essential, as Mahesh said. The other piece is it's multi-generational, right? So if, in our book, the last section on the anthology is on purpose multi-generational. So when you go look at that, there are people that preceded us and people that come after us chronologically in age, to be very specific. And it's a really diverse group of people. We have Rena Pandey had been at .46 Ventures. We have Lisa Guano Davis, who'd been in pharma and had a really interesting educational setup from when she was young. And we have Jan Berger, who had been the first chief medical officer at CVS. And we've learned from all of them. So this notion of community, we have always set up around ourselves, even if we didn't realize what we were doing. And that's really essential for us, because when you try to go to all the other communities around just straight MBAs or other areas of industry, unless there are clinicians in it, there are some nuances we don't get. Now, that cross-fertilization between all of those sectors with clinicians is essential. So I'm not negating that notion, but there is something about clinicians and our education, regardless of area, whether you're a pharmacist, a nurse, a PA, a researcher, a doctor, that we all have and we understand our language. And maybe part of it is support group, but the other part is we can trade stories and best practices this way and move the entire community forward to become the leaders that we need in health.
Yeah, when I started at Optum, I was under the wing of Reza, And the first couple months, I was just watching him in action, and I can't even tell you like what I learned just watching him. It's not something that I could write in a book. It's something I wish he had had a GoPro on his head and we had recorded it. Like that would have been amazing.
It was before GoPro, Alex.
I
Yeah, we
know.
all did this before all of that.
You know, one of the things I've noticed, at least on the value-based care side, is that it's a limited number of people who've done full risk value-based care delegation efforts, right? And it used to be even smaller, focused in Southern California, you know, and so on. But in the last 5 years, there's been this massive growth in digital health solutions. So now there's a new wave of clinician leaders that are in the product side, they're on the sales side, they're on the kind of the solution side, and they don't fully understand their customer. So there's two parts of this, right? There's the, can I drive value in my current company and product, translating, you know, figuring out if this is the right approach or that is the right approach with the swab we use, etc., right? And, you know, we try to support folks there. You know, Alex has been quite experienced in digital health and friendly PCs and so on. But understanding the customer takes much longer. And, you know, we hope in our course, and I'm sure, you know, your book and so on, is to help educate folks that if you're creating value, like to this entity, to the world, like who exactly are you creating value for? Is it affordability? Is it risk adjustment? Is it quality? Like they have all different silos and economic buyers. What's been your sense? And as you talk to nephrologists, maybe Mahesh, right? Like there's traditional nephrologists, and then there's this value-based, you know, kidney care efforts, etc. Like how far have we come in the frontline nephrologist understanding even their own value-based nephrology, their own field, and what more do they need, let's say, in the next 5 years?
Yeah, I don't think this is specific to nephrology. I see this across all sectors that are doing value-based care. You know, our complexity is that as clinicians, we are trained to take care of individual patients, right? That's how we're trained. And the first thing you have to learn is how do you take care of populations, right? So I have an MPH for that reason. And so how do we, and our book has a mini MPH section in it, but how do we think about the population, not just the patient? Really difficult to get across, right? I'll give you a small anecdote. When I was a chief resident at the VA here in DC, one day I showed up and the chief of radiology, not the resident chief, the actual chief, was sitting in my office really pissed off. And I'm like, what are you mad about? He's like, do you know what one of your residents did? He tried to take an x-ray. He needed an x-ray last night, couldn't find the tech, so tried to do it himself. I got the machine, tried to make it himself. And so I called the guy in my office. I'm like, A, what the hell were you doing, right? You probably gave that guy, you know, too many exposures because it probably was a little bit of trial and error. But B, we only have 2 x-ray machines in the entire facility. If the x-ray machine went down, 50% of people the next day wouldn't get them. And the epitome of the lack of training that we have is he turned to me and said, Mahesh, I have to do what's right for my patient at that time. I don't really care what happens to the rest of the system, right? And that's sort of the way we're taught. So that's problem number 1. Problem number 2 is that we don't understand the fundamentals of sort of business management of that, right? So if you have a population, how do you allocate resources? You can't spread your resources like peanut butter, right? Like I've seen numerous organizational and individual efforts at value-based care fails because the answer is if I do something for Reza, then I should do that for everyone that I see, right? Well, that's not the case. Reza might be sicker or more healthier. We cannot spread interventions like peanut butter, right? You're guaranteed to undertreat a certain amount of people and overtreat another set of people, and that's just the wrong thing to do. But this fundamental lack of understanding of systems design that you point out, Reza, is a really big problem. And then the last thing is we are beaten into us that we should be passive, right? Mm-hmm. Like we're like, oh, the system isn't working, I guess I'll just work within it or work around it, right? Rarely do people say the system isn't working, let me go fix that system, right? Let me go figure out how to address the problem, do a root cause analysis, propose some ideas and make it better. we're just fundamentally not trained that way, and we have to get out of that mentality, right? That in order to move forward, we sort of have to unlearn some of the things that we learned in the past and make progress.
I have a question for you. When I've done any sort of serious, high quality writing of my own, it's always been the writing process itself has been a discovery process where I'm actually discovering certain ideas and connections between ideas that I didn't actually know beforehand. So did you experience that as you were writing this book? And like, just talk to me a little bit about the process of writing and how that felt and what you learned from it.
I would say absolutely. Part of it was I learned that Mahesh is really good about writing about finance so that I can understand it. So the running joke between the two of us is, for years, we call each other when we have some random question about something that's going on. And we don't understand, or in my case, I get a little impatient about, and I'm like, what are the key takeaways? So the beauty of this book is each time we wrote a chapter, regardless of which of us was writing it, we're both editing, right? And so we learned first and foremost so much from each other. And again, we've known each other for years, kind of like you and Reza, right? We've known each other for years, yet we still have two different styles. But the things that came out of the book were, when we were writing it, I was like, oh, I forgot this concept. Oh, I remember this is really helpful. That's one, total discovery, especially when you have a partner in writing. I mean, to me, this was just joy for the most part, and just a luxury of time that we didn't have before to do this and to dedicate to this. I think the other piece was we know what we can't do. We had really good editor, really good typesetter, really good person to get it up and published. We became publishers, so we have a publishing house now, and we became bigger authors. And those things were important. In addition, when we talk to people about what we were writing, I am always like, oh yeah, I'm writing this thing. And they're like, this is huge. This is really important. I'm like, nah, it's this little thing. You know, I don't know that I'm ready to birth it. I've birthed 2 children, but I don't know if I'm ready to birth this. And so the notion of actually having your ideas out there in print in more than like a page and a half or a scientific paper, I think frankly for me was a little bit scary. So pushing that edge was important. And both of us do tons of public speaking. It is not the public speaking part. It was literally having my words in a book that someone's going to see and be like, I don't know.
Let me ask a technical question as we're going to wrap up somewhat soon. For those of us in the audience who are looking to write a book, maybe their first book and so on, walk me through the trade-offs between having your book on Amazon, what percentage they take, like, you know, having your first print be a couple hundred versus a couple thousand, right? Like, maybe you guys have done some of this before and you have a broader audience, but for those who are getting their first book out, how do you think about some of those tactical things that they're trying to decide in terms of self-publish or big publisher, et cetera, et cetera?
Reza's trying to get some free consulting because I just wrote a book.
So I've done it both ways. So I've written 2 or 3 other books as well way back in the day. And way back in the day, I've written them, like the pharmaceutical book we talked about that for academic medical center detailing. I printed that myself and I self-published it. Look, I think getting a publisher is really difficult, right? Especially if no one knows you, right? If you've got a huge blog or something like that, maybe you can get a publisher. But realistically, it's quite difficult to get a publisher. And the more niche your market is, the more you don't need them, right? Publishers are really important in the end game to really promote your book. And if you have a mechanism to promote your book, I think that's reasonable. The advantage today, and our book is exclusively on Amazon right now and or via our website, but the advantage of publishing it on Kindle is a print on demand function. And so you can literally upload the files and then they'll just print them on demand. So you're not incurring, as I did way back when, the amount of cost that's required to maintain inventory and do the shipping and all that sort of stuff. You literally say, when your readers order the myriad of books they're going to order after this great podcast, Amazon will literally print it on demand and then send it to them, right? So there's no fixed inventory. Or again, with their Kindle framework, they'll just download it to the Kindle, and that's an easier framework. You pay for that, right? You set your price. Ours is $18.99, and then they take a non-significant amount, depending on the publishing side and the shipping side versus the electronic side. So your net is probably 50% on the paper version, and maybe slightly higher than that on the electronic version because the cost of goods are lower. But I would definitely recommend it. It's really, really an easier way to go. There are other channels you can use, but I think today self-publishing using the Kindle format and the Amazon print-on-demand format is really the way to go. It just simplifies a lot of different things.
I think the other thing I'd add is, in talking to our good friends who have published through publishers, again, great route to go. But we had a majority of our book already written when we started considering how do we publish this. And there's a lag with publishers, rightfully so, right? It's 18 months or more where you're developing the book, and then there's a channel and they have a timing. We just wanted to get this thing out there. We also wanted it to be global quickly, and it is. And, you know, having done a couple of talks on the book already to different clinician groups, you know, we had one meeting that was 50. It was so easy for them to order the book, get it right there, and me walk in without, as Mahesh said, the heavy carry in front. But again, the lag with the publisher is significant depending on where you are in the development of your book.
Amazing. So before we wrap up, how about any kind of last final thoughts for physicians who are trying to advance their career? Would love your final thoughts from each of you.
I think physicians are lifelong learners. You have already gotten a lot of the skills, you probably just don't know it, that are translatable into the business environment. And so regardless of whether it's our book or the Clinics course or something, it is quite important to be intentional about the skills that you acquire, right? You would not want to go to see a surgeon that's never done a surgical residency, right? You don't want me, the nephrologist doing bypass surgery. You'd want me to, but you might go see me if I did a residency and did some training and had some cases, those sort of things. And so it is a game that requires intentionality to go learn. It's not something you're just going to pick up. Any smart person can do anything if you're willing to tolerate cycle time and errors. The complexity with tolerating cycle time and errors, if you are in corporate America or in an organization, is that those are hits to your reputation, right? Those are hits to your ability to move your idea forward, to go from concept to reality. And you can mitigate those errors and the cycle time issues by just learning, right? Go and approach, you'll see the way we talk about in the book, go and approach finance the way you would have approached physiology. Go and approach marketing the way you would have approached patient communications. Go and approach the ability to create a milestone in a plan and organize the way you'd run a code, right? You don't just show up and say, oh, okay, what do I need to do? Epi? I don't know. Maybe I'll use bypass. You don't do that, right? You got a plan. And so I think you got to approach it with that same discipline, right? Just think of these as different medical subspecialties or medical things you have to learn in school, and approach it that way, and really take an active role. And then, as Shami says, look at people who are successful at it, right? In any organization, clinicians are great, right? You look at the number of clinicians that are out there that run organizations at various different levels, find what works for them and what doesn't, and try to mimic those things and try to be a continuous student and really subject yourself to continuous improvement. It is the biggest mistake you can make is to assume that you're smarter than the MBAs and you're smarter than everyone else because you have an MD, and just walk in there and that will crush your ability to be successful and crush your ability to improve healthcare, get done whatever you want to get done.
And I look at it as, how do you accelerate time to effectiveness, right? So reading our book and following Clinics and taking courses with you guys is one way to accelerate your effectiveness. At the end of the day, as we say in the front of our book, all of us have gone to medical school or nursing school or PA school, anywhere you are, to become a clinician to really help reduce patient illness and suffering. And we really do believe that the more clinicians that are trained to lead in these environments, the better we get at alleviating suffering for patients, at allowing people to have the tools and then give the tools to communities and populations to make the world a healthier and better place. And we don't say that tongue in cheek. That's really why we wrote the book, and that's what we hope people find from it.
Wow.
Our slogan, Alex and Reza, is if you're going to fix healthcare, it's going to be easier for clinicians to learn a bit of business than it is for the business people to learn all of medicine and then make the right decisions.
Exactly.
Absolutely brilliant. So again, the 60-minute Clinician MBA, it can be found on Amazon.
It can be found.
Amazing. Shami Feinglass, Mahesh Krishnan, thank you so much. This was truly amazing. Thank you.
Thank you, guys.
Thank you.